Good morning. As part of our academic program, we are regularly conducting surgical audit at MR Bangur Hospital. Today is a surgical audit. Three units will be presenting their audit. The first audit will be presented by Dr. Mehul Patel, say audit for Unit 1 General Surgery. Mehul, you start.
Good morning, respected teachers and my dear colleagues. I'll be presenting Unit 1 audit for the month of November under Dr. A.K. Kaur and Dr. Audit. Total OPD days 9, total admission days 11, total OPD patients 923, total number of elective OT days 9, total OT planned 39 hours 20 minutes, table 1 lab 17 hours 15 minutes, open 22 hours 5 minutes. Total number of minor OT days 10, total time in minor OT 11 hours 40 minutes, total number of mortality 0, total number of morbidities 3. Total elective admissions 46, emergency admissions 23, total elective operations 39, emergency operations 15, minor operations 17, mortality 0, and morbidity 3. In hepatobiliary and pancreatic and splenic surgeries, 7 cases of chronic calculus cholecystectis for which laparoscopic cholecystectomy was done. One such case was converted to open. One case of acute and chronic calculus cholecystitis was also converted to open cholecystectomy. One case of choledocholithesis in a case of recurrent cholangitis and pancreatitis, and past history of open cholecystectomy done 1 year back, for which choledocholitheotomy with repair over TT was done. And one case of chronic calculus cholecystitis for which lap cholecystectomy was done, which was followed by an exploratory laparotomy and a repair of CBD rent. And gastrointestinal and perineal surgeries, 3 cases of anal fissure for which lateral internal sphincterotomy was done, 2 cases of fistula and ano for which fistulectomy was done, 2 cases of internal hemorrhoids for which stapler hemorrhoidopexy was done, 2 cases for internal hemorrhoids for which hemorrhoidectomy was done, 1 case of recurrent appendicitis for which lap appendectomy, 2 cases of recurrent appendicitis for which lap appendectomy was done, 2 cases of recurrent appendicitis for which open appendectomy was done, and 1 case of ileostomy, double barrel ileostomy for which reversal of ileostomy was done, and 1 case of ileocolostomy for which the reversal was done. In hernia and groin surgeries, 6 cases of unilateral inguinal hernia for which Liechtenstein mesh herniaplasty was done, 2 cases of paraumbilical hernia for which herniaplasty was done, 1 case of ventral hernia for which herniaplasty was done, and 2 cases of umbilical hernia for which herniaplasty was done. 1 case of varicose for which lap varicocelectomy was done. In breast and endocrine surgeries, bilateral gynecomastia for which bilateral subcutaneous mastopexy with mastectomy with Benellis mastopexy was done. In emergency operations, 2 cases of hollow viscous perforation for which exploratory laparotomy followed by Cullen-Jones repair was done. 1 case of perineal abscess for which incision and drainage was done. 1 case of parietal wall abscess for which incision and drainage was done. 2 cases of carbuncle for which ID and delooping was done. And 1 case of breast abscess for which incision and drainage was done. 3 cases of acute cholestatic pancreatitis were managed conservatively. 4 cases of acute calculus cholecystitis were managed conservatively. 1 case of acute appendicitis for which appendectomy was done. 2 cases of foot cellulitis with compartment syndrome for which fasciotomy was done. 5 cases of diabetic foot ulcer for which debridement and dressing was done. Total minor operations done was 17. We have 3 morbidities, 1 male and 2 female. Morbidity number 1, 68-year-old male, follow-up case of open cholecystectomy done 1 year ago with features of recurrent cholangitis and pancreatitis. Investigations was done and he was diagnosed with choledocholithesis. He was planned for choledocholitheotomy after resuscitation. Patient was operated without any complications. On POD5, the patient developed mild pus discharge from the wound site. It was managed conservatively with regular dressing. Morbidity 2, a 68-year-old lady was planned for laparoscopic cholecystectomy. Post-operative, there was daily bile output of around 300 ml. Count on POT3, total leukocyte count on POT3 was 16,000, pulse 120, and saturation was 95% in room air. Emergency laparotomy was done on POD4. A small rent was seen on the CBD. Primary repair with PDS 30 was done. Uh, Thorough wash with normal saline was done and drains were placed. The bile output has gradually decreased to about 25 ml per day. Blood parameters, including the LFT, is within normal limit. Patient is on normal diet and ambulating with the normal stool passage. And USG whole abdomen done showed no collection in the abdomen. The patient is planned for discharge. Morbidity 3. A 42-year-old woman was planned for laparoscopy cholecystectomy. Intra-op, there was gross adhesion. Stone was impacted in the GB neck. And there was inadvertent injury to the left hepatic duct. The procedure was converted to open and a primary repair of left hepatic duct was done. On POD5, USG was done, which showed subdiaphragmatic collection. The patient was taken up for emergency laparotomy. The collection was drained and drains were placed in subdiaphragmatic space, HRPM, and valves. The patient gradually improved with normalization of all the blood parameters. Now, drain output gradually decreased to less than 25 ml. The patient has been discharged and is on regular follow-up.
Go back to the last slide.
Yes.
So I find there are good number of lab chole related problems.
Yes.
So this patient was got this is what
Lab police.
how do you understand that you have done a left hepatic duct injury? Because left sided injury is not very common in routine cholecystectomy.
So actually, so the anatomy was while doing the operation, so it was a bit difficult to understand. Whether it was not the usual. So then
How
after,
did you suspect that yes, there is a
so there was
ductal injury?
so there was a we could see some bile leakage.
And
So
then converted?
it was converted to open, and then it was found out that it was left.
Okay. Previous one.
Yes.
Is it this patient who has got a injury and uh, how did the patient behave in the post-op period?
So in the post-op period, sir,
How was the patient progress in about 3 or 4 days time?
yes, so the patient said didn't follow the routine pathway that a lab chole patient goes.
What was the problem?
The patient was toxic. Say she was having breathing difficulties, and there was
What about pain?
she complained of pain, sir.
So she might have unusual pain.
Yes, sir. More than which usually stays.
Mhm. And then why did you plan for a emergency laparotomy?
So
Because
because
these are the patient who are laparotomy has more morbidities.
hmm,
Because here the primary on fourth post-op day, getting the CBD, getting the rent is a very difficult situation because there are a lot of flakes, a lot of inflammatory
yes, sir.
flakes on the side. So on fourth post-op day, getting the rent, repairing it is not a very good option. So these are the situations where you can think of doing re-laparoscopy because the idea is to drain the bile. In this phase, the idea is not to get into because it is very difficult to find the exact nature of injury also. So here the idea should be draining the bile. Okay, Ronit is online.
Yes, sir. I am online.
Yeah, yeah. Ronit, what is the decision for doing this primary repair on the fourth post-op day?
So basically, we don't. Usually, we don't repair the CBD in the post-op day 4.
In fact, it
But
is very
in this
difficult.
case,
In fact, it is very difficult to find the rent.
but sir, in this case, the area was not that much adhered, and a small rent was visible in the anterior part of the CBD, and the bile is coming out. So we have
Yeah.
thought to put a T tube and repair it, but as the rent was very small, we just did a primary repair. But it is said that in infected case, because it is an infected case, the primary repair it will leak. But we don't have other options, so we did a primary repair.
That's what I'm saying. If you cannot stent, if you cannot
Yes, sir.
stent this patient might keep continuing with the more of post-op bile leak, and then the chance of biliary stricture will be more in the follow-up. When you repaired, you said bile but will gradually decrease 25 ml. What happened in the initial post-op days? How much bile was draining?
So around 100 ml.
100 ml. For how many days?
4 days.
3-4 days.
Sir, initially on POD1, there was a bile of around 300 ml in the bag. Gradually, it decreased, but the patient was gradually becoming worse. The abdomen was gradually become distended, and the pulse rate was continuously on the higher side. So we have done a USG
Yeah.
whole abdomen. It shows collection. So we have decided for a emergency laparotomy.
Again, a trap. Most of the time, we do USG in the post-op period. They said
Yes, sir.
minimal collection, and minimal is
Yes,
not
sir.
minimal because USG is not a good investigation to assess
We have to do a CECT whole abdomen, sir.
post-biliary collection.
Yes, sir.
If the patient has got clinical evidence on between patient as guarding rigidity, even if the ultrasound shows minimal collection, it is wise to put the scope again and have a look because most of the time ultrasound cannot assess the exact amount of collection. If at all you need to assess, it should be a CT scan.
Yes, sir.
Okay.
Yes, sir.
Another
Yes.
case I find there is intraoperative, you say, convert to CVD rent repaired.
Mm.
So that was intra CVD injury.
This
No, no, no.
Yes,
That you
sir.
did not
Yes, sir.
POD4. No, no.
intraoperative. Oh, this one.
Sir, in
No,
the
no.
introp the rent, the injury was detected and we repaired it. But in the post-op period, we did a CT scan. It shows a loculated collection in the subdiaphragmatic region.
Oh,
But we have tried for pigtail so many areas. We have referred it to SSKM. We have referred it to the ultrasonography people. They didn't.
the lesson is you should be more cautious. You see, out of
Yes, sir.
10 cases, if 3 cases has these sort of problems, we should be more uh, number one. You should avoid taking a acute cholecystitis for lab cholecystectomy.
Sir,
You
we
might have gone
didn't
to the last CBD
take.
conference where others Chaudhary from Medanta said they have a policy not to operate acute cholecystitis.
Yes, sir.
Even
Yes,
if
sir.
there
Yes.
is a recommendation to operate on acute cholecystitis, but there is a rider for that. The rider is this should be done by a person who has got special training in performing lab cholecystectomy, number one, and that should be done in a very good center. Is that should be done in a upgraded center. So it is on our part, it should be wise to avoid doing cholecystectomy in acute. Most of the time, we are treating acute cholecystitis constantly agreed, but we should
Yes.
avoid doing because you see, if the risk of uh, complications are so high, if out of 10 cases, 2-3 patients has severe injury, it is a massive incidence. So you should be more cautious in approaching these patients because you see, lab chole is a very simple operation, but once you land up with problems, it creates a biliary cripple. Surgeon is in problem, patient is in problem. Okay, go back, go back. Then the list of the operation. You see, hollow viscous perforation. You see, today you know where is the perforation. So you should specify what perforation it was. It was peptic perforation. Okay.
One in pylorus, one in
One in pylorus, one in the one
Sir, 2 cases.
or 2 cases. So you specify what is the perforation. If there is a pylorus means stomach, you mean.
Hmm.
So what you should do even if there is a gastric perforation, it's not only repair, you should do something else also. What you should do? What is the age of the patient?
So 65.
65. 65 patient,
So we
gastric
sent for
perforation.
biopsy, sir.
Yes,
We sent, sir. Sorry,
that you should mention. These are 2 different cases. If you have a gastric perforation, what the report came as?
Not his. It has not yet come.
Not yet come. Because that is important. If you have a patient who's got a gastric ulcer perforation, patient is elderly, there is a risk that it might be malignant. Ulcer which is perforated. Go back. Go back. You said lab. You said lab varicocelectomy. What is lab? You have excised the segment. You don't excise the segment of vein. It is lab palum. What we have done?
So we took out the cords and
You took out the cord. How could I took out the
sir,
cord?
we dissected
You dissected the cord and ligated the and clipped the
clip those
testicular vein.
test
So that is what. It's not varicosilectomy means you excise the segment of dilated veins. That is varicosilectomy. In lab, you don't do that. In lab, you do a high ligation of the testicular vein. Okay, near the deep ring. So this is lab Paloma operation, not varicosilectomy. Okay, fine then. Thank you. Okay. We pass on to the surgical audit of Unit 2 under Dr. J. Roy. You ask Niloy to join.
the links in the group.
He's in the group. Dr. Roy does not join. He's busy. Dr. Shoham will be presenting audit for 2.
Good morning, sir. Surgical audit for November 2023 of Unit 2, General Surgery, under Dr. J. Roy and Dr. N. Noshka. Elective admissions 28, emergency admissions 17, elective operations 28, emergency operations 8, minor operations 13, morbidity 1. Total OPD days 8, total admission days 9, total OPD patients 746, total OPD patients new 454, total OPD patients old 292. Total number of elective OT days 9, total time in OT, planned OT 32 hours and 15 minutes. Table 1 lab 11 hours and 10 minutes. Table 2 21 hours and 5 minutes. Total number of minor OT days 8. In minor OT 6 hours and 40 minutes was spent. Total number of morbidities 1. In hepatobiliary and pancreatic and splenic surgeries, there were 10 cases of chronic cholecystitis which were managed with laparoscopic cholecystectomy, and one chronic calculous cholecystitis was managed with lap converted open cholecystectomy. Ileostomy in gastrointestinal and perineal surgeries, one case of ileostomy with stoma reversal was done. In hernia and groin surgeries, unilateral inguinal hernia, hernia raphe was done in 3 cases. In umbilical hernia, 3 cases of hernial anatomical repair was done. In 1 case of congenital hernia, herniatomy was done. In 1 case of hydrocele, Jabelis procedure of eversion of sac was done. In 1 case of paraumbilical hernia, anatomical repair was done. In 1 case of bilateral hernia with umbilical hernia, mesh hernioplasty was done. Unilateral inguinal hernia, Lichtenstein's hernioplasty was done in 4 cases. In 1 fibroadenoma case, excision was done. 1 foreign body in hand, removal of foreign body under C-arm guidance was done. In emergency operations, foot and leg ulcer, 1 case of foot and leg ulcer was managed by debridement and dressing. 1 case of chest wall abscess, incision and drainage was done. 1 case of parotid abscess, incision and drainage was done. 1 case of scalp hematoma, incision and drainage was done. Acute 3 cases of acute appendicitis, appendicectomy was done. 1 case of cellulitis and compartment syndrome of the right thigh and lower limb, where
Forum, you say?
there was a
Mistake.
change.
Hmm.
Left thigh and leg and foot, extensive debridement was done. There was no compartment syndrome. In emergency admissions, 2 cases of acute gallstone pancreatitis, 4 cases of acute calculous cholecystitis, 2 cases of subacute intestinal obstruction, and 1 case of splenic trauma grade 3 was admitted. All of them were managed conservatively. In minor OTs, there were 12 cases of sebaceous cyst excision, one case of dermoid cyst excision, and 2 cases of lipoma excision. And there was one morbidity. A 68-year-old female with no known comorbidities was diagnosed with spigelian hernia and umbilical hernia. Patient was planned for elective hernioplasty, and both the hernias were repaired after proper pre-anesthetic checkup. On POD2, while dressing POD3, while dressing, there was 10 to 15 ml of serous collection was noted. Sorry, POD2, while dressing, there was 10 to 15 ml serous collection was noted from the umbilical hernia wound. The same finding was noted during dressing every alternate day. The wound incision of spigelian hernia uh, at present is fine. At present, on POD8, the patient is the discharge has decreased, and the patient is planned for discharge at present.
What is the last what is the patient profile? What is the, you said umbilical, and in adult it is not an umbilical hernia, it's always a perumbilical hernia. So what is the size of umbilical hernia? What is the size of spinal hernia?
So the size of the umbilical hernia was 2 by 3 centimeter.
Okay.
And
Spigelian?
Spigelian, the with CT scan reports.
Clinically, what was the
clinically the patient had a vague cough impulse. The patient is
vague cough impulse.
The patient was extremely obese. She
So it's very
complained of
difficult.
pain in the area. It was in the left side of the patient.
Very obese means BMI?
BMI was more than 35.
So here the patient should be asked to lose weight. A umbilical hernia of 2-3 centimeter and spinal hernia of doubtful palpability. Here the patient who should be electively asked to lose weight and come for surgery. Because this is see the post-op problem. Okay, yes, what incision you have given for these 2 surgery?
Sir, one was
2 incision.
2 incisions.
Where?
Sir, one was over the umbilicus.
What is the length of the incision? Vertical or transverse?
So transverse.
Transverse, umbilical, and then?
And another was along the languid line.
Where?
On the spigelian.
So these 2 incision is not continuous?
No, sir.
What is the distance between the margin of these 2 incision?
So there was around 5 centimeters, more than 5 centimeters.
How can it be 5 centimeters? If you say umbilical hernia and then you got left-sided spinal hernia, yes, you made incision the umbilicus to put a mesh, that should be something you have to mobilize the flap and do the part, and then spigelian. I don't find any rationality for this 2 separate incision for umbilical and spigelian. These are the patient who should be better managed laparoscopically, number 1. Number 2, even if you operate, you should give one single incision. Raise that flap. This is the hernial gap in the umbilical, dissect the spigelian gap. How intraoperatively diagnose spigelian with the flap? What is the diagnostic point for a spigelian hernia versus a hernia which is an initial hernia coming out through the side?
So there was a history of LUCS.
Patient is LUCS also earlier.
Earlier, and it was more than 22 years. But
no, LUCS might be a fenestral incision.
Yes, yes.
And spigelian are talking of where?
Yes, near just below the arcuate line, and there was a
spigelian hernia below the arcuate line.
Like just at the.
What is spigelian hernia?
So spigelian hernia is a hernia that.
What is the site through which this hernia occurs?
Just along the semilunar line.
Yes.
Generally below.
And if you while operating, raise the skin flap, do you find the hernial sac straight away or find something else?
No, just after the
skin flap is raised.
Just after the skin.
Usually the external break appears.
Yes.
Usually, external ripple is intact. Once you inside the clinical appendicitis, you find the hernia sac. So this is not the proper technique for repair for a joint hernia. How do you work? You make a umbilical incision and then you make another incision the spinal. Why not make a long apple? She's obese. I could have done abdominoplasty. If I have done a long apron incision, with the same apron incision, I could have excised a segment of this redundant skin, some amount of fat, and then raise the flap, do a adequate space, and place a mesh. What is the length of mesh you place in the umbilical hernia?
20 by
20.
no, it was taken, but it was cut into approximately 10 by 12.
Umbilical 10 by 12.
No, 10, not umbilical. The
Spinal.
spinal.
And what about umbilical?
Umbilical, there was actually sir did anatomical repair.
Then you said umbilical you put a mesh.
After that,
You see, you should follow some standard protocol. You cannot go by your own whims when you repair. Dr. I is not there, I cannot discuss with him. But you should think of doing a standard repair for a standard hernia. Once patient has got this sort of discharge, discharge from the surface.
no, sir. There was like while tracing,
so there is a rent in the wound.
serous fluid is.
There is a rent in the wound. So have you seen this for culture?
There was no pus.
The other problems. The other patient who might have subsequent infection. The mesh was placed in which plane?
Above the.
It's only mesh.
Yes.
Even for spinal, it is only mesh. You close the layers and then put the mesh only.
No. It was.
You understand what are the different
yes,
layers so I put the mesh? If you are doing this umbilical and spinal yarn, the mesh has to be placed in the same plane. Have you created a retractor space? In the umbilical area, have you created a retractor space? Or you close the gap and put the mesh over the sheath? देखो तो, you see, observe. You close the gap and put the mesh on the umbilicus. And then the spinal, same. Why? Nothing to discuss. Chalo, this is not the standard technique for repair of dual hernias. Go back. Back.
Makunda, good morning.
Yes.
I have a suggestion.
Yes, sir.
A small suggestion. If there are multiple hernias in the past, we used to do open technique, midline incision, anatomical dissection, and then put the mesh in the retrorectus plane. And that will solve the umbilical hernia and the and the spinal hernia both. Separate incision. This is called retroperitoneal mesh placement from one antesuperiliac spine to another antesuperiliac spine. And put a big mesh. Don't cut the mesh and put a big mesh and close the abdomen in anatomically layer. And retroperitoneal dissection is very easy and you can do it. So that is the simplest technique. And only mesh will definitely get infected in this case. And did you put any BDVAC suction drain in this case? Because you have fatty woman and big
very thinned
lady.
out. You cannot create space in a retractor space. Yes, agreed. Go back.
So that solves the problem. So we should learn this technique. This technique is very easy. Just a laparotomy incision and
excision. Yeah.
And then it will cover the weakness of the previous finasteride incision also.
Yeah.
Because it might come back with a hernia because she is obese in 5 years time. So cover everything.
If you create the retractor space below the arcuate line, you will be covering this area behind the Cooper's ligament also. That takes care of the previous incision. Yes.
Takes care of everything.
Yeah.
I prefer this technique. Thank you.
Okay. What is this patient profile of fibroadenoma? Patient age, size, and why did you decide to operate this patient?
So actually the size was 4 by 5 centimeter and the age was 45 years.
45 years?
Yes, 40.
How do you diagnose fibroadenoma in this patient?
So clinically, there was it was moving under the skin.
And
There
then,
was no
and
fixity,
then, what is the
and
histological
FNAC
proof?
was done.
You did FNAC.
FNAC was done.
You do FNAC for all 45 years, lady with this lump may be malignant.
It's a USG and
That is what I'm saying. If you are operating on 45 years, lady with a 4 cell lump, I agree that I'll operate even for a fibroadenoma. But how to prove? It's not FNA. 4 centimeter lump in a 45 lady, the standard of care should be two cut biopsy. You do two cut biopsy regularly? You know how to do two cut biopsy?
Yes, sir. Yeah.
So FNS was done from outside.
Yes.
That is not the standard protocol for a evaluation of a lump in a 45 years lady. So follow the standard protocol. Sure. Back. पीछे जाओ. What is your criteria to select patient for doing herniorrhaphy versus hernia? You have 3 cases of herniorrhaphy, 4 cases of hernioplasty.
So this was like surgeon's choice.
Surgeon's choice. Is not patient profile,
No,
gap. It is only surgeon choice.
So herniorrhaphy is done.
If I ask you exam question, how do you answer?
Sorry.
You have a patient.
In emergency.
You have a patient who is 60 years, has got a direct inguinal hernia. What should be the standard repair for this patient? 60-year gentleman with a direct inguinal hernia. What should be your preference for repair?
So Liechtenstein.
You have a 30 years young adult patient who has got a complete inguinoscrotal hernia and it is W3.
If it is in emergency, we can really.
No, I'm not asking emergency. I am talking of the elective situation. 30-year gentleman having a inguinoscrotal hernia of some duration and it is W3. W3 means 3-finger gap. So, because I'm asking you because in exam you have to give a standard answer.
Yes, sir.
Just because you are seeing some herniorrhaphy and then exam you say I do herniorrhaphy, examiner may not agree. So there are some standard recommendation, and whether I follow my recommendation or not, that is my different issue. But in a teaching institution, we at least expect that we will teach our students the standard techniques of surgical repair. Okay. Some are umbilical, some are paraumbilical. How do you decide? How do you decide this is umbilical, this is paraumbilical? 3 are umbilical. I don't write umbilical for any adult patient. Umbilical is umbilical. You understand what is umbilicus? The umbilical rent is present in utero when this cord structure emerges. And a child is born with a swelling there, that is a true umbilical hernia. A neonate born with a swelling coming through the umbilical hernia. In an adult, where the umbilical cicatrix has sealed off, he come back with a hernia. It may not be that original hernial flap which is exiting this hernial content. It is always a paraumbilical. So try to define this. Clinically, you find there is a swelling. You see, most of the time you'll find that the swelling is bulging on one side of umbilicus. When it is large, the whole umbilicus is bulging. But initially, as it started on one side of umbilicus. In fact, the umbilicus one side is inverted and other side is showing a bulge. So these are all basically paraumbilical hernias. So it's not necessary in adult. As I said, if it is a 1-year child, I'll agree it's umbilical hernia. But in adult patient, is no point dividing this something as umbilical because ultimately the whole umbilical will bulge. When the hernia is getting bigger, starting with a paraumbilical, it will bulge the whole umbilicus. So that doesn't mean this is umbilical hernia. And someone having a small hernia is paraumbilical. So in adult, make a practice that in all adult, these hernias are all paraumbilical hernias. Then how do you decide? Again, there are some standard guidelines for repair of ventral hernias. Okay, try to give a idea about these hernias based on EHS classification. Why does it fall in EHS classification? If you say parumbilical, M1, M2, M3.
So M2.
Why M2? It should be M3. Okay.
So M2.
Next time you present with the EHS classification. And then the gap. What is the standard recommendation? Because I find again you are doing some, most of the time I'm doing a repair, most of the time sometimes mesh, and even if you put a mesh, you see that although only mesh is described and people are doing, but the points in more of favor is doing a rectoratus repair. Okay, how do you create a rectoratus space? If I am dissecting the umbilical area, how do you enter the rectoratus space?
Not seen any.
You have not seen a rectoratus misplacement. Ah, my goodness. Chalo, you rotate, you'll find. Chalo, go back. What are the ILS to be done for?
So
Maganda, good morning. Maganda,
Yes.
good morning. He is a first year student. All right. So we must tell him that without putting a mesh, repairing a hernia is nowadays is the offense. Please note
I
it.
cannot say that. It's not an offense. But yeah, what I'm trying to say is the standard, you see, there are some standard guidelines. If the
You
hernial
must.
defect is 1 to 2 centimeter, you can still do a anatomical repair. Beyond 2 centimeter, then if you say in 10, if you say in a patient who has got a hernia defect of 5 centimeters and you anatomical repair, you are doing a wrong practice. Okay, so there are some guidelines based on the defect size. That's why the EHS classifications come up. In EHS, they are dividing this into W1, W2, W3 to at least give an idea that W1 is a small gap, W2 is the intermediate gap, W3 is a large gap, and extreme gap is when it is 8 or 10 centimeter, where you cannot do this. Last
Yes,
day
yes.
we did a peritoneal flap repair. It was a large gap and elderly patient thinned out. We have utilized the peritoneal flap to bridge the defect. Okay, go back. The ileostomas for what?
So there was appendicular perforation with
Why?
in
When it was done?
September. So,
Patient with appendicular perforation.
so appendicular perforation, there was appendicitis.
Previous appendicular we have done.
Yes, sir.
And then we said there is a serosal tear.
Yes, sir.
Serosal tear can be repaired.
Um,
If there is a serosal tear, that does not mandate that you should do ileostomy.
so
You see, it's a very morbid procedure. And at what gap reverse the stoma?
so, it was around. So actually, I don't remember.
You should remember that is done in your period of.
It was in September. So,
Go back. What is the reason for conversion of this lap cholecystectomy?
so the callots we dissected properly. The,
If callots is frozen,
yes,
if callots cannot be dissected and you are in, what else can be done rather than converting this patient to open?
so,
It's a good decision that If surgeon is not converted, he should convert to open. So before opening, what other things can be thought of?
So there are a few bailout procedures.
Bailout, good. Bailout procedure. What are the bailout procedures? How do you decide? What are the landmarks? What are the landmarks which will help you to bail out?
It's a partial
No, that's what I'm saying. While doing partial, you have to follow some landmark that I will not go beyond that. One is reverse sulcus. Was the reverse sulcus seen in this patient clearly?
Yes.
So if reverse sulcus is seen, you can open the gallbladder there, take the stone out, and suture that. That is a form of subtotal cholecystectomy, number one. Reverse sulcus is not seen, callus is frozen. Any other guideline to approach?
Yes.
What was that line?
Recording in progress.
What was that line? Segment fold line.
Segment
What is that?
R4U line.
R4U line is a line I talked earlier.
Oh, sir, segment 4 line above that it's safe. Below that it's
No,
not.
that's what I'm saying. What is segment fold line or D line? So the segment 4 is where between the
Segment 4
ligament of teres and the left border of the gallbladder. That is a segment 4.
Yes.
You draw that line. And then keep your dissection on that line above, not below.
Above is safe.
So these are the two bailout. Next bailout. Next bailout is fundus first. Fundus first. Okay. The best is to convert to open if you are not conversant with the bailout procedure. Otherwise, there are some other techniques that you can bail yourself for this sort of frozen calories. Okay. Dr. Rai does not join, so how can I discuss with him? Chalo, okay. Dr. Kaur, you may like to make any comment?
No, nothing.
Okay. So next will be by Dr. Prasenjit Basu for audit for Unit 3 General Surgery.
Makhanda, hello.
Yes.
I have got a suggestion to the newcomers to surgery. Practice open cholecystectomy from time to time. You will see some patients who is not interested in going for laparoscopic cholecystectomy. In the OPD, they will come and tell Doctor, I want to go for open procedure. So in those cases,
No, we don't
call
find
me.
such patient now. We don't find such patient now. This used to get earlier. Now any patient coming to OPD, they'll opt for lab. We have to make them understand that sometimes we do open to train our PGs, but now very difficult to convince patient that get a open surgery done.
No, today
But,
I'm lucky.
I agree that
lucky.
We should do open.
At my OPD at KPC, one patient came and told, I want to open procedure. I said, fine, go on. So that my boys learn the open technique.
First. Yeah. She came and said open because she'll quote you that one of her neighbor has died of lap chole, or that patient required 2 or 3 operations following lap chole.
whatever the background, but if someone comes for open, go for open.
You see, my job in the OPD will be to convince that patient that there is no. You see, even if you do open, you might need to do twice. You can injure the bite at open surgery.
We may
So it's not that open
trouble.
surgery always safe, but I always prefer to have some open gallbladder patient to train our PGs that they should also understand how to do open surgery. Unit 3, chalo, come on.
Thank you.
Good morning, sir. I am Dr. Prasenjit Bhushan and I am going to present the surgical audit for the month of November 2023 for Unit 3, which is headed by Dr. M.L. Saha sir and Dr. S.S. Mishra and Dr. Midin Alabji. Here is outpatient summary. Total APD days 9, total admission day 11, total OPD patient 1074, new patient 684, old patient 390. Total number of elective OT days 8, total time in OT planned table on lab 36 hours 10 minutes, table to open to 32 hours and 15 minutes. Total number of minor OT days 11, time in minor OT 20 hours 25 minutes, time in emergency OT 15 hours 26 minutes. Total number of mortality 1 and morbidity 3. Elective admission for the month of November 23 we have 56. Emergency admission 22, elective operation 43, emergency operation 15, minor operation 48, mortality 1 and morbidity 3. Elective admissions, we have hepatobiliary and pancreatic splenic chronic cholecystitis. We did lab cholecystectomy for 13 cases and open cholecystectomy for 1 cases. We have cholelithiasis with cholecystectomy. We did cholecystectomy with cholecystectomy for 1 case. One patient with cholelithiasis with cirrhotic liver, we found it intraoperatively. We did diagnostic lab and we abandoned
and you should add abandoned
the procedure. Yes, sir. And for hernia and groin surgery, bilateral inguinal hernia, we did TAPP for 1 case. But diaphragmatic hernia, we did primary repair.
What type of diagnosis it was?
Sir, posterior lateral.
That is Bogdale. So you should specify at the end of month when the diagnosis already made, give a complete diagnosis.
Yes, sir.
This was a left posterolateral hernia, Bogdale.
Sir. For unilateral hernia, we did Lichtenstein Mace herniaplasty for 9 cases. For single unilateral inguinal hernia, which is congenital inguinal hernia, we did herniatomy. For umbilical hernia, we did anatomical repair for 1 case. A paraumbilical hernia, we did mesh herniaplasty at retrorectus plane for 1 case. Incisional hernia, we did mesh herniaplasty at retrorectus plane for 1 case. Gastrointestinal perianal fistula, we did fistulectomy. For recurrent appendicitis, we did laparoscopic appendectomy for 1 case. A case with colonic dysplasia with
not dysplasia, multiple polyposis.
Yes, sir,
from cecum to rectum.
Yes, sir.
And rectal lesion was
also proliferative growth is
so,
also there.
Why is for collective?
Yes, sir. With midgut volvulus with malrotation of gut, we did diagnostic laparoscopy, then open LATS procedure done. Invasive ductal carcinoma of lip, we did BCS for 1 case. For miscellaneous phimosis, we did circumcision, lipoma excision, pilonidal sinus excision with limbar flap repair for pilonidal sinus. Emergency operation, we did open appendectomy for 3 cases. 1 case which presented with acute intestinal obstruction, we did exploratory laparotomy, followed by extended right hemicolectomy with double barrel ileostomy. Another case which also presented with acute intestinal obstruction, we did exploratory laparotomy followed by left hemicolectomy with colic anastomosis with diversion ileostomy. Irreducible umbilical hernia, we did mesh hernioplasty done at retrorectus plane with umbilectomy and omentectomy.
In diagnosis,
Yes,
you should give the complete diagnosis.
Yes.
You see, on these 2 cases, one has obstructive right colonic growth.
Yes,
other has obstructive left colonic growth. Very unusual to find 2 such patients in a span of 1 month.
So the back. Sorry, these are some emergency admission. We did conservative treatment for the acute pancreatitis, acute pulmonary and left foot cellulitis with type 2 and hypertension. Minor operation list, wedge biopsy.
Done 50 minor operations.
Yes.
Chalo, ठीक है.
Morbidity 3 cases and mortality 1. First morbidity 72-year female presented with feature with acute intestinal obstruction, proper After proper optimization undergoes exploratory laboratory in which a mass is detected in hepatic pressure. We proceed for extended ischemicolectomy and double viral ileostomy. Done. Patient was doing well up to QD4. Then collection developed at surgical site, which is managed conservatively by regular dressing and IV antibiotics. It responds well, and after successful conservative management, we discharge the patient. Second, morbidity of 45-year female is presented with features of implementation of proper optimization. After proper optimization, it undergoes exploratory laparoscopy in which a mass is detected in descending colon. A left hemicolectomy was done with colocolic anastomosis with divergent ileostomy. Patient was doing voluntary collection detected at surgical site. Patient is managed conservatively and successfully conservative. Patient discharged. These are patient of 48-year female presented with paraumbilical hernia with miss herniaplasty done at retrorectus plane. Flap necrosis develops on
This is
POD4.
what type of necrosis this is? It's a major necrosis or minor necrosis?
Minor necrosis, sir.
Yes. So this is a minor flap
Yes, sir.
necrosis.
Yes, sir.
This you can always manage conservatively.
Conservatively manage it and discharge the patient successfully. A single mortality is there. A 75-year-old female is presented with a history of fall from height, followed by head injury. Her GCS on admission was E2, V2, and M3 with gasping breathing pattern. We try to resuscitate the patient by endotracheal intubation in the ward and put on TP's mode of ventilation as no CCU bed is available on that time. IV fluid is given with inotrope support to correct the hypotension. All the conservative management failed and patient is on cardiac arrest after 30 minutes of admission and succumbed to death.
This patient has GCS of how much? 7.
Yes, sir.
What does it indicate?
Sir, airway compromised. Sir. And
this indicates what? This indicates severe head
severe
injury.
head injury, yes, sir.
And these are the patient. Any patient with GCS of 8 or less,
yes, sir,
has to be electively ventilated. I find you have intubated, but put on T-tube.
Sir, there is no ventilator available in the ward.
That you say, that you specify.
And CCU is
This is
not
the patient. These are the patient who has this sort of scoring in GCS.
Yes, sir.
These are the patient who should go to CCU and to be ventilated.
Yes,
There's no point taking the patient to the ward and put in a T-piece ventilation. Number one. Number two, most of the patient of head injury does not have hypotension.
So once it is.
No, that's what I'm saying.
Yes.
A patient who has got a coma scale of 7,
yes,
you have intubated, yes, and you could have put AMBU. Even ventilation, you could have put AMBU and then keep on ventilating.
Sir, initially,
have you tried to find the cause for hypotension? See, patient has fall from height.
Yes.
Because in most of the patients of head injury, hypotension is not a very common phenomenon if it is an isolated head injury.
Yes.
So what you have looked for? Does the patient have a because patient died very rapidly on admission. Does this patient have hemothorax? Does this patient any abdominal injury? Does this patient any limb injury? Have you done that complete examination?
Sir,
have you undressed the patient?
Sir, there
or
is,
you remain busy with the...
We undress the patient initially for primary survey we did.
Yes. For primary survey, you need to undress the patient.
Sir, on the secondary survey we did.
No, primary survey at the end.
Yes.
A, B, C, D, E.
Yes,
One you have done A, B, C, D, then E comes where you expose the patient. What do you have looked for?
Sir, there is no active bleeding.
No bleeding, number one. What else? Active bleeding means there is no external wound.
No external wound, yes, sir.
Apart from not having an external wound, patient may have bleed inside.
Yes, sir.
The elderly person, 75 years. Fall from height can cause a fracture.
Yes, sir.
Have you excluded a fracture?
No, sir. There is no sign of any
no
asymmetrical chest
no limb
movement.
No, I'm not. I'm talking about peripheral limb first.
No, sir.
Falling from a height and 75-year lady, the first thing to happen is a fracture.
They give the history that they slip from the staircase and become unconscious, and they come
slip from the staircase, not fall from.
Yes, sir.
Try to understand.
Yes, sir. Yes.
If the history should be proper.
Yes, sir.
Someone has slipped in the and fall down. That is not fall from a height.
Yes.
Fall from a height is fall from the first floor or fall from some elevated areas. Give a proper history.
Yes.
So sleep can cause
And-
some other injuries.
Yes.
Where?
Can I add something, Makanda? Hello?
Yes.
Hello?
Yes.
First thing, you must remember, any head injury will produce hypertension. This is called Cushing's reflex. Because to supply the blood to the brain, the heart rate reduces and the blood pressure increases. This is Cushing one. Two is, if the patient, 75-year-old male, may have a myocardial infarction, which is causing hypotension, and for that he might have fallen. So or there may be concealed hemorrhage, which Professor Shah has already discussed, and there may be fracture for which he has fallen down. So these are the points you must remember. Additional point. Thank you. Thank you.
And then try to understand. Whenever a patient of trauma comes, don't follow the critical care specialist protocol of putting on inotrope. A inotrope can damage, can harm the patient who are being resuscitated. When you put inotrope in a trauma scenario, try to think of a trauma scenario and vis-a-vis a situation of critical care.
Sir, first of all, we give the fluid challenge at the rate of 30 ml per kg per hour. If it
30 ml per kg per hour. Fluid
Yes,
challenge.
Yes, initially
Huh?
for the soft patients, sir.
Right. 30 ml per kg per hour. If it's 60 kg, it become how much?
Sir, 1 liter challenge is given.
Then why do you say 30 ml per kg per hour? You understand how much it comes?
Yes.
Huh?
Yes, sir.
It comes to almost 2 liters.
2 liters. Sir.
Patient will die 75 years later.
Sir,
In a patient of 75 years, the initial filter is 500 ml only. At which you can do 1 liter.
1 liter.
Basic জিনিসগুলো তো জানো হচ্ছে না ঠিক. You must understand the basic trauma resuscitation.
Yes.
Huh? And then
Sir,
when do you put, suppose I have given this 500 ml.
Yes.
Patient has responded.
Yes.
And then again gone down. Again gone down. That means after maintaining BP for about 15 minutes, the BP is going down. Is it the time for giving inotrope?
No, sir. It indicates it is transiently responded.
So patient has more volume loss.
More volume loss.
So correct the volume unless you have a central line where you can measure the CBP.
Systemic venous.
When you can measure CBP or more, now you have the invasive ventilation, invasive methods in CCU.
Yes, sir.
It's not only your CBP. CBP is faulty in many ways.
Yes.
What is the ideal way to assess in a trauma when a patient is hydrated?
Sir,
You have a gadget. You've seen that CCU. You'll find there is a gadget which gives you a lot of parameters. That gadget gives you cardiac output.
Yes.
That patient can give you pulmonary capillary wedge pressure, which are more reflection of adequate hydration. If you have ultrasound, you can do ultrasound abdomen and find the IVC diameter. If IVC is collapsed, that indicates that patient is underhydrated. So once you are convinced that the patient is given adequate volume replacement and then patient is not coming up, then comes the question inotrope. Inotrope in trauma is not a very important consideration. This will harm, this will cause vasoconstriction.
Yes.
Okay, that is not the proper way of managing patient like this. No. Patient dying after 30 minutes means it's a very severe injury. I agree. And with a coma scale of 7. But we should follow the standard protocol of management. Okay. In fact, this is a patient who not to be admitted in MR Bangalore. We should do initial resuscitation and then refer the patient. This patient might have a compressive intracranial hematoma. This patient might have a compressive intracranial hematoma. We have not done anything. It's not possible to do a CT scan for this patient.
No, sir.
So
it is directly admitted by EMOs.
I understand. They admitted because patient is sick, that somehow patient should be taken to the ward. But telling that this is the patient not to be shifted to the ward.
So we usually counsel the patient party to take them to a trauma center or
No,
the health
trauma
center.
center, you see, but you see, patient who is hypotensive, patient die on the way. You should be at least convinced that the patient can be shifted.
So after stabilizing, only,
That is what I'm saying.
after stabilizing, we try
That
to.
is what I'm saying. Because these are the patient, if they are not ventilated, they will gradually grow down.
Yes.
So if the patient body wants the patient will die here, that is different. But you see, the two ways of approaching such patient. One is to explain the patient the extent of injury, what facility we have. If this patient does not have a compressing hematoma, no point sending the patient to trauma center. What they will do? Same can be done here. If the patient has got a compressing hematoma which required decompression, there is a justification for sending the patient to a trauma care center. Otherwise, this patient without a compressing hematoma, he will go for ventilation. That ventilation facility you have here. Give them what else? Nothing. These are the patients who just require ventilatory support and a supportive treatment. Because you see, indication for transferring patient to a neurosurgical center is the patient is requiring or will require a neurosurgical intervention. Otherwise, there is no point referring. If the neurosurgical center is occupied by all these such patients, the patient coming hematoma will not be admitted. So resuscitate, do a CT scan, assess. If the patient has got a situation that surgical intervention will be helpful, patient has to be accommodated there. Then you have to take an extra care that you communicate with these people. This is a patient who's got a compressing hematoma, needs urgent intervention, and definitely they will take. There's no point pushing all the patient to MR Bangur with a coma scale of 7 or 8 or 9. Okay. Okay. Thank you. Any last comment, Dr. Basak, Dr. Kaur?
No, it is a good, it is a good session. And one thing I want to add is Pascal's law. You will read in physics Pascal's law. In hernia, you must remember the Pascal's law. Pascal's law is a law where abdomen is a barrel. If you put a mesh onlay, the chance of recurrence is very high. Always put the mesh inlay and retrorectus. That will give you the best result. That's the read Pascal's law.
There are some situations where only has to be done when the layers are very thinned out. We can put it only. Only is not an obsolete situation now yet, but only can put. But the better way of placing the mesh is a retracted. That is also a very pertinent point.
When there is inseparable addition, you can put only. There is no issue, but better to put retrorectus. Thank you.
The problem with the only is if the wound break down for some reason, skin flap necrosis, the mesh get exposed. The mesh get exposed.
And another thing is, I always put a BD-back suction drain in large hernia meshes and things, so that it absorbs the seroma, drains the seroma, and it is a closed drainage system. So chance of infection is less. If you do a lot of dissection, anatomical dissection, then it is better to put a BD-back suction drain. I don't know whether Makhunda will agree or not, but the BD-back suction drain saves this seroma.
We drain routinely.
Always routinely drain with
we have gone beyond time.
Bye bye.
Thank you.
Good day. Good
Thank
day.
you all.
Good day to all. Thank you. Bye. Bye.
Bye.